some brief housekeeping announcements. Waverley Gates has a fire alarm test every Tuesday at 10 AM. If the alarm sounds at any other time, please make your way out the fire exit at the back left corner of the hearing room and down the staircase to your right, which will exit onto Colton Road, the muster point for the inquiry. Please follow these instructions unless advised otherwise by a fire marshal, and if in doubt, follow the green emergency exit signs. Do take a moment to familiarise yourself with our hearing suite etiquette. This can be found on the hearing suite TV screens now. There is a cafe on the ground floor selling hot drinks and snacks, but we kindly request that you only consume water in the hearing suite. You can help yourself to water in glasses, which you can find in the kitchen next to our reception desk. Inquiry staff are wearing orange lanyards. Please approach them if you require assistance. Please ensure that your phones, laptops, and any electronic devices are on silent mode. Device screens may be captured on the broadcast during wide shots of the hearing suite. All attendees are kindly asked to stand when the inquiry chair enters and leaves the hearing room. A member of the inquiry team will inform you when to stand. Please remain at your seats until the chair and witnesses have left the room. Thank you for your attention. The hearing will start in a few moments.
Now, good morning everybody. Good morning Dr. Segal and Sir Ashley. Now, everyone ready? When you're ready.
Thank you, my lord. Good morning, Sir Ashley, Dr. Tegel.
Morning.
The next topic under theme 3 that we're moving on to this morning is care homes, and the inquiry is particularly interested to hear a bit more about the non-pharmaceutical interventions that were put in place in homes for care homes for the elderly and in other care home settings, for example, for those with profound intellectual and multiple disabilities. So we'd like to spend some time this morning considering those under the following broad headings: general information, visiting, the role of family as carers, testing, other infection prevention and control measures, for example, bubbles, PPE, access to healthcare, and the use of do not attempt CPR orders. And I think if we can start with general information, and you've already both given us a bit of information about this during yesterday's discussion. I think you've explained the use of care homes in your countries, but I'd like to provide you with an opportunity to add anything relevant that you think in relation to sort of the general background in terms of the use of care homes to what you told us yesterday, and also to explain a bit about how community care operates, particularly for those with profound intellectual and multiple disabilities. So if we can perhaps start with you, Sir Ashley.
Well, thank you very much, and good morning, my Lord, and good morning to everyone. Yes, so just to recap on a couple of comments I made yesterday, our care home delivery, whether it's for aged residential care or for people with disabilities, intellectual and physical, is publicly subsidised or funded through the health care system. So it's not, it's part of the healthcare system, and the services are commissioned through the healthcare system. There's a national contract with, a nationally consistent contract with all of the care providers, and in the case of aged residential care, that is, there are approximately 660 of those, or there were at the start of the pandemic. Most of those providers, there's been a shift over the last 2 or 3 decades to consolidation of those providers to larger private, and many of them corporate providers. And there are very clear standards, quality and care standards that they are required to meet. And this would apply equally to the delivery of care for people with disabilities. In the case of aged residential care, the access to the government subsidy is means tested, and for most people, they would be paying something on top of the payment that's made, the public payment that's made. One other comment I would make, just to reiterate what I said yesterday, it's a very well organised sector, both the aged residential care and also the sector that provides home-based care, which is also funded through the health system. So they have very active and very well-connected peak bodies, and this, of course, is important at any time in terms of ensuring that there is good communication, and of course very connected to and advocate on behalf of their sector with ministers. But when it came to the pandemic, it meant there were extant strong relationships, networks, ways to get information out, and also ways to canvass information and input into the requirements that the aged residential care sector would need to meet to help protect both residents and staff working in those facilities.
Thank you very much. And just a follow-up question in relation to something you said yesterday. You indicated that, it goes back to testing, you indicated that testing was mandated for healthcare workers. Did that include testing for care home staff as well?
Yes, that included testing for care home staff, and that was a very important part of the quite intense protocols around protecting people within care facilities, was regular symptom checks and testing of the staff there, and they were also under the vaccine mandate requirements too. The other part about that was the care facilities had plans with their local district health boards to support staffing if they had staff off who couldn't attend because they were unwell. So that was a really important part of making sure that that there was every incentive in the system for staff who were unwell not to come to work.
Thank you. And in terms of the testing, did that also apply to those engaged in community care, either for the elderly or those with profound intellectual and mental disabilities?
I would have to check whether they were subject to compulsory testing. They certainly were subject to the compulsory vaccination requirements, and I would have to just check to see if they were part of the compulsory testing.
Thank you. If we can, just before we go on to the next question, if we could ask Dr. Tegnell if there was anything you wished to add in relation to the general setup of care in Sweden.
No, as I said before, it's quite different in Sweden. Some 40 years ago, the long-term care was taken away from hospital services and given to the communities and became a kind of social service instead. But otherwise, there's a lot of similarities. They are run by the communities, but they are most often operationally run by different kind of companies, taking over more and more. But they all, even those ones, are subject to the same kind of rules that everybody else has. So the people living there paying a small fee, depending on their income and so on. So it's heavily subsidized by the communities. But you also need, and I think I made that clear, you also need to see that in a legal sense, where they live is their home. Which means that many of they have a fully equipped one-room apartment, so to speak, in most instances. And it is legally their home, which comes back to our discussion about stopping visitors and so on. So it is even legally a completely different kind of setup than it would be if it was a kind of hospital. So I think that's important to realize. And that when this was set up, of course, there was a realization that they needed some kind of support with medical expertise. But that was left to a high degree open and said that this would be dealt with by agreement between the communities and the health services. Those agreements has only come in place in like 30-40% of the cases and so on. So in some instances, in some relations, there is a very good collaboration. The hospital hygiene people are really very present and helping them. But in some instances, there is sort of really no real good connection anymore. And that so many of them are run by private actors makes that even more difficult. So, so it's more a kind of a supported home solution than anything else. And the other thing is that the priority in Sweden has really been to make it possible for people to live at home as much as possible. So this has been a very, very strong trend. So instead of moving people with disabilities or elderly people into different kind of institutions, there is a massive kind of support for staying at home. So you can have visitors 5, 6, 7 times a day at home with different kind of categories of. But also those are normally run by the communities, unless you have some kind of medical condition. Then, of course, also the hospital services will be involved. And I would say all hospitals or health system in the regions also have an outreach section, so to speak, with where they provide medical care in your home.
Okay, well, that's interesting because we'll come on to discuss the accessibility to medical care as well. If I could ask you, Dr. Shannon, what's the average age of residents in elderly care homes in Sweden?
I don't really have the exact figure, but I know it's well above 80. We talked about before, I think average lifespan when you enter it, we're talking about a few months.
And in New Zealand, what is the average age?
It would be in the 80s. And even then, I think it's important to say, most people over 85 or even over 90 still live in their own homes with either family or other support. So whilst we have a higher proportion of the elderly population in these facilities, it's still a minority of older people who are in the care facilities.
Thank you. And just, we spoke earlier, are people with profound intellectual multiple disabilities recognised as a distinct group in New Zealand with specific needs in, for example, education, health and social care?
Yes, very much so. And I should point out that for up until mid-2022, services for disabled people were also funded and commissioned directly from the Ministry of Health. So there's now a separate ministry for disabled people. That was part of the health system reform that was implemented in mid-2022. But for most of my time in the public service, disability support services were actually commissioned and funded out of the Ministry of Health, so centrally. And a very strong disability community in terms of the advocacy for that community and involvement in the informing the development of policy and funding and care delivery.
And where are people with these disabilities usually cared for? Is it residential homes at home with family in the community, what is the general trend?
Well, the majority would be in their own homes with family and with a range of care support, depending on their need. A small minority would be in care facilities. And most of these would be owned by not-for-profit trusts. They're not publicly owned per se.
Thank you. And what is the position in Sweden, Dr. Tegnell, both in terms of recognition as a distinct group and in terms of where they're usually cared for?
Yeah, definitely recognized as a distinct group, and also quite strong advocates for that and for their rights and so on. So this is continuously a big discussion in Sweden. And they do get a lot of support, but the support is coming out of the communities as a kind of part of the social services. Fairly complicated. They are very sort of, unusually for Sweden, very detailed regulations on what they are entitled to and what they are not. And on top of that, a reform was initiated some maybe 10 years ago when they do actually employ their carers themselves. They don't pay for them, but they are their employers. And this has created some problems because it has been misused. These days we have quite a lot of discussions. It's actually organized crime to a certain extent that misuses this kind of system. So it's under heavy review and so on. But I think the basic background to it was a positive one because it really wanted to give the power to the people so that they could get the kind of care and the kind of care they wanted to have. But they get extensive care, and just like with the elderly, the goal is really that they should be able to live at home. And once they get to be adults, they should also have their own home and get the support to be able to have that.
Thank you. If I could ask Sir Ashley, you mentioned in your report that aged care facilities were identified as a setting of particular concern in New Zealand. At what stage was that recognition?
Very early on, and in part this was just an understanding that older people were at higher risk. Anyway, it tend to be at higher risk based on what happens each year with our flu outbreaks, and also in that setting where they're in close contact, with regular contact with carers and of course other residents. And we were also looking at what was happening abroad, including in the United Kingdom as well as in the US in particular, in New York, and in the European jurisdictions that already had outbreaks. So it was clear from early on this was a high-risk setting.
Thank you. And if I can ask Dr. Tegnell, in Sweden, was it, I think you answered yesterday that it was recognised, and when was that?
Also very early on. The data from China already was quite clear about it, and as we discussed yesterday, part of the pandemic plan was really to identify and recognize and work with high-level risk groups. And eventually, when it also hit Italy, it became even more clear. And I even remember the Italian ambassador coming to our agency and just inform us about the risk for the elderly people, which had shown so very, very clearly in Italy during the first waves there.
And were both care home residents and staff recognised as being at greater risk of contracting COVID-19 than the general population?
Yes, maybe not more contracting, but definitely having worse outcomes. We have looked at seroepidemiology, the number of how many of these people actually had contracted the disease at any time, and it was reasonably low level compared to the population at large, with higher levels. So I don't think it was the risk of getting infected that was higher. It was very much the risk, the outcome.
And did that apply to both residents and staff, the outcome, potential outcome?
Yes, staff. We did look at different professions, and we could see that professions that met many other people had a higher level of risk, of course, and these groups had higher level. It is complicated by the fact that a very high proportion of the people working in these kind of facilities have a background in other countries, which meant that they also ended up in that risk group. We know that risk group had a higher risk of getting infected due to a number of different circumstances. So it was sort of a double risk, very much one, that they were out and moving about and meeting a lot of people, but the second also that they socially were in a group where we had a higher incidence, especially in the beginning of the pandemic.
Thank you. And if I could ask about the New Zealand situation, were care home residents and staff at greater risk of contracting or developing symptoms of COVID-19 than the general population?
Well, we anticipated that if we had a community-wide outbreak, that would be the case. However, because we went into an elimination approach, when we went into that first lockdown, we already did have through that period, we had some infections in rest care facilities. So I think I mentioned yesterday 6 of the 660 facilities did have residents who became infected, and we saw very quickly that they were at much higher risk. That was where, I think, just recapping yesterday, we had just over 50 deaths in the first 2 years of the pandemic, and more than half of those, my recollection is, would have been in rest care facilities. So even the small number of infections we did have were, demonstrated that actually this was a very high-risk setting. And that's why it became a huge priority to work very closely, and we had a team in the ministry that was dedicated to working on a daily basis with that sector, and likewise there were people in each district health board that worked very closely with the aged residential care facilities in their area. They would do that anyway because they had the direct relationship with them and would be visiting frequently. They would know who the managers were and who the key nursing staff were, so those existing networks were able to be used very effectively to support infection prevention control, implementation of visitor policies and so on.
Great, thank you. And in Sweden, was protection of the elderly an explicit priority, and to what extent that was achieved? And I ask this against the background, I think you say in your response that Sweden failed to protect the elderly.
No. From early on, it was a high level of priority, and we went out early on with also giving specific advice to the elderly on how to protect themselves in different ways, and also, of course, made clear that elderly care homes were at high risk. But the complication in Sweden was that they were not really run by any of the normal contacts we had. So there were several levels that needed to come through to really reach them. Some of them did a fantastic job and even could sort of show that they had procedures in place and so on that could stop the spread in there, but many of them didn't. And so the outcome was very bad. And I think during the first wave, we had like 70% of the deaths in these kind of care facilities were only like very small. I said about 10,000 people are living. So it's the increased risk when you lived in those kind of facilities was very, very high. And to the extent that actually relatives and so on did keep their elderly relations at home. People were too scared to, because everybody realized that it's high risk to put my elderly parent, whatever, into one of those facilities. So a few of these facilities was actually more empty than ever as a result of the risk that existed there.
And I think you mentioned, that people were reluctant to put their family members in. Was it possible to move people into care homes during the pandemic, for example, from hospital or their own homes?
Yes, and it did happen. And we had big discussions on what kind of level of certainty you would need before you moved them in, how many tests you needed to take and what kind of intervals and so on. So, and these, I think, worked out, and we also took developed guidelines on what you can. If you move somebody from hospital care into a care home after having COVID, how you need to ascertain that you are not taking the disease with you. And our impression was that was not the risk, really. The risk came heavily from the staff. Every time we did any kind of, or anybody did any kind of more contact tracing activities, it was quite clear that the start of the outbreaks in the elderly homes almost always came back to staff.
And was it possible for people to move out of care homes if there were these concerns, for example, to return to families?
Yeah, I mean, as I said, these are their homes, and of course they are free to do whatever they want.
And engaging in community activities, was that permitted as well?
Yeah. So, I mean, they had the same freedom of everything as everybody else.
Can I ask a question, Dr. Tangle, please? We've heard evidence in this inquiry that, as well as the risk of staff working in care homes bringing in the infection, care homes, of course, depend on supplies being delivered, all sorts of supplies, and that was at least proposed as a possible conduit for bringing infection into care homes. Was that something that was looked at all in Sweden, or did you have any evidence that suggested that was a route of transmission?
Not really, and I think also, I mean, most investigations really pointed back to staff. And I think it also makes kind of sense because you need a fairly close, I mean, we can discuss airborne or not airborne, but you need a fairly close contact to infect, and then it sort of made sense. It's the staff who has the close contact, nobody else. I mean, the people bringing stuff there could possibly infect staff, maybe. I cannot say anything. I mean, the next level was difficult to ascertain. But these people not only meet staff very closely, they also meet very many different staff very closely. So their exposure was extreme. I mean, because it was not, I mean, normally you would say in these kind of circumstances you should go to a cohort kind of treatment. But most of these, where you have a restricted amount of people meeting with the sick people and you don't have staff going from somebody sick to somebody healthy. But this didn't really work very well. They didn't have the structures in place to be able to handle that, which meant that a person living there might meet like 7, 8 different staff every day. And of course that increases the risk enormously of meeting somebody who is infectious.
Thank you. If I could ask Sir Ashley, was it possible to move, and I'm thinking particularly at levels 3 and 4, was it possible to move into a care home during the pandemic from, for example, hospitals or home, and equally to move out and go back home?
Yes, both were possible, and there was a lot of movement into and out of, and as we discussed earlier on, the tenure of people in these facilities, particularly at hospital level care, is relatively short, and a lot of people would be discharged. Some older people would be discharged from hospital into a care home for either a period of rehabilitation or permanently, and so that did continue. And I guess there were two scenarios. When we were in our alert level 1 during the elimination phase, of course we were COVID-free, and so it was a relatively smooth and normal process. Once we had our larger community outbreak that started, in particular in the Auckland region in August 2021, then there were very strict protocols put in place for testing requirements, as Dr. Tingle has referred to, and some care facilities would then isolate the person from other residents for up to 14 days as an additional protective measure. And of course, this was on top of very stringent requirements around visitors and requirements for staff to use PPE, to the symptom check, daily symptom checks, and testing as indicated too.
Thank you. And in terms of guidance, or sort of broadly, in terms of were care homes treated effectively as residences or hospitals in terms of restrictions and IPC measures?
A mix of both, I would say. Just treated as a very high-risk setting, and there is this balance, of course, between the fact that these are the facilities are people's homes, and so they need to be able to be visited by relatives and so on, and the fact that especially for those people in hospital or dementia level care that they are more like a healthcare facility. So very similar infection prevention control measures and requirements on staff in terms of testing and use of PPE. And very detailed guidelines were developed in which are available on the internet in late 2020, detailing what should happen in a care home if there was an outbreak of any kind, and the responsibilities on each facility to have in place plans ready to activate.
And what type of guidance was that? Was that similar guidance that was being given in relation to other settings in terms of the operation of care homes and social care in respect of infection prevention control?
Very bespoke guidance because of the nature of the setting and the staffing requirements. And as an example, as I mentioned earlier on, is it's great to have staff not coming to work if they're unwell, but then you've still got the challenge that people need their care needs, their care and health needs need to be met, and so there were plans in place with the district health board for district health board staff to go and support as required, and these plans were implemented on a number of occasions.
And I think you've probably answered this already in the previous discussion, but was guidance on recommendations or laws provided to implementers and service providers, and did they have any input into that guidance, specifically in relation to care settings?
So the care facility, especially through their peak bodies, was extremely. This constituency was extremely active in wanting to be part of and promoting a nationally consistent approach across care facilities, and in supporting access to PPE and testing and so on for their staff and residents. So there was absolutely no problem in getting them engaged, nor in and there was a very high expectation and a very good working relationship at both local and national level to ensure that there was tension at times because of expectations around access to PPE and testing that may not have been available or that needed to be used in a way that perhaps the aged residential care sector didn't think was consistent with their needs, but there was very active involvement in the development of the guidelines and in the providing feedback on their implementation. So there was this constant iteration as well to make sure that anything that information that became available or any learning was incorporated into updates.
And I think you mentioned in your response, you refer to healthcare workers being asked for their opinion, which helped form the basis of decisions. Is that what you're referring to there? Or what were they asked about and what decisions did that influence, if not?
So Dr. Tegnell and I were discussing this earlier on. There was no problem in getting feedback, especially from experts, and sometimes it was even solicited. But very often it would come through the media. But there were just channels for regular meetings, regular communication with a whole range of groups, including professional groups, and the aged residential care facilities would be representing the interests and the providing feedback of the staff from the staff, both the care workers and the health staff who worked in those facilities. I should say one other comment is that it's outside of pandemic time. Each aged residential care facility is required to have a relationship with a primary care or a general practitioner. And those general practitioners would know the residents and be coming in quite regularly to provide, because these are people with high healthcare needs. Often they're on a number of medications, they've got chronic diseases. So there would be those established relationships and arrangements. And so those continue to be used through the pandemic as well.
Thank you. Dr. Tegnell, if I can ask you then, to what extent were care homes, and you've mentioned they were people's homes, but to what extent were they treated as residents or hospitals in terms of restrictions or IPC measures?
Not exactly the same way, because they sort of run in different systems, so there was a need to sort of adapt. But we very early on established a specific working group working together with hospital hygiene experts and people from elderly care facilities to develop guidelines for them. So guidelines were developed very early on and iterated over and over again. But I mean, the problem was really that even if these guidelines existed, the staff didn't really have the training and so on to fully implement them all the way. And especially in the early days, there was also a severe lack of protective equipment in those facilities, and unfortunately also a severe lack of possibility to test, especially the staff but also the residents. On top of that, a lot of the staff, surprising amount of the staff, is are still employed on an hourly basis, which means that they fall out of the normal system in Sweden of getting compensation when you're sick. So, of course, the incentive for those groups to stay home when they felt ill in the morning, which we really had compensated in other ways so you wouldn't lose money, did not apply to those groups. And I know from a survey in the Stockholm area that about 30 or 40% of the staff in elderly care homes are employed on an hourly basis. And, of course, it means that they have no incentive to stay home, or because they also, with the social economy and so on, they really need to go to work get enough money to survive. But it also means that they don't have the training, they are not included in the systems and the quality development in the facilities. So there was a number of weak spots in these kind of places on many different levels that made it very, very difficult to improve the quality of care there as quickly as was needed.
And in terms of guidance and recommendations, was that provided? You've already said that was provided, but did they have any input into that guidance, I'm thinking?
Yeah, no, there were representatives from these elder care homes involved in that. And so they definitely had a possibility to see to it that they were adapted to their possibilities.
Thank you. If we can move on then to visiting and family involvement, and perhaps start with you, Dr. Tegnell. Could you explain broadly the nature and extent of any restrictions on visiting care homes? And I think you've probably answered this in your answer about the fact that this is people's homes, but if you could just explain broadly the nature and extent, if there were any restrictions on visiting care homes, both for elderly residents and for people of all ages, including those with profound intellectual multiple disabilities, and whether that was by phase in Sweden or...
Yes, early on when we saw what was happening in the elderly homes, there was a blanket ban on visitors to the elderly homes in the first spring. And that included all facilities, even included hospitals, so no, any kind of facility like that. Later on, as we moved on and we had discussions both with our ethical committee but also with our legal advice and so on, it was quite clear to us that this was not really neither ethical nor legal nor probably effective, because we got more and more information from the contact tracing that took place in these kind of places. And as I said, exclusively I would say that it was the staff that took it in, and this is not finger pointing at the staff and saying that there's something wrong, but they had that kind of relations with the people there that made transmission possible. While visitors already knew what it was all about, they kept a lot of distance. They often took the elderly people outside and met outside and so on. And many of the elderly homes also installed different kind of screens and stuff like that. So there was definitely a lot of measures in place that stopped the transmission from visitors, which meant that we took that away, and we actually went the other way. And together with the government, there was a decision taken that you can only stop visitors in your elderly home if you have very, very good reasons to do that. So the elderly homes who wanted to do that, which number of them wanted, because having visitors took a lot of staff needed to spend a lot of time on that, and it was quite complicated during this period, and there was a worry and all of that. So a number of elderly homes really wanted to have a ban for visitors, but then they needed to go to the local communicable disease officer and get their approval, and then it will end up with us at the Public Health Agency to sort of decide, do they have sufficient grounds to actually stop visitors? And after that, none of the elderly homes had a blanket ban on visitors. So during the rest of the pandemic, people were allowed to visit. And I still think that this visitor ban really caused a lot of unnecessary grief, because if there is something people really regret, is the possibility, lacking the possibility to say goodbye to their elderly relatives and so on. I think that was really sad.
Thank you. And if I could ask the position in New Zealand then, broadly the nature and extent of any restrictions on visiting care homes, both for elderly residents and for people of all ages, including those with PIMD.
Yes, so even prior to the first lockdown, there were both in aged residential care facilities and in the community, many older people were already modifying their behaviour, and in the care facilities they were already implementing a range of measures, including restrictions on visiting and strict requirements on physical distancing and so on. So when we went into the first lockdown, my recollection is there was pretty much a ban on visiting, and perhaps it was less a ban, but just because people were required to stay at home, yes, they didn't go visiting, and many families decided not to put their relatives at what they felt might be an undue risk. So saying, in the actual alert level framework, in both the most stringent level 4 and the next level down, level 3, in theory, these facilities could have visitors, but there were very strict protocols that were required around symptom checking and use of masks and physical distancing and so on. This sort of restriction on visiting applied also in hospital settings, and I agree with Dr. Tegnell that this, perhaps one of the key lessons was there was a very restrictive approach applied, at least through that first lockdown, to accompanying people to hospital, even women who might be delivering a baby, family members who might be very unwell, dying in a care facility, but people couldn't visit them. And of course, at that point in time, there was so little we didn't know, and as more information became available, we realised that with strict protocols, then visiting could be done safely, or having a person accompany someone into a hospital. And just to reiterate the point that Dr. Tegnell made as well, that actually this was an additional, this was a challenging environment for the staff working in these facilities, and so navigating visitors coming in and the protocols that were required was an additional burden on them. So in fact, my recollection is that the care facilities themselves were quite keen on quite strict requirements being put on them, so that they could use that to help manage the challenge of having visitors and all the protocols required around that.
Thank you. And during the times that visiting was restricted, how were relationships with family maintained?
From the stories that people told me, the care facilities got very good at in enabling their residents access to devices so that they could keep in touch with family members through use of Zoom or Teams apps, and that was a really important part of helping people remain connected to their family. Of course, that was happening outside of care facilities too, so I think this was seen as a really important part of supporting people to remain connected to their family members and their friends.
And when visitor restrictions were in place, was end-of-life visiting permitted in New Zealand?
My recollection is during the first lockdown that there was even a significant restriction, at least at the start, on that, and that because people couldn't travel from around the country and were required to stay unless it was for work or expressly permitted purposes, that they couldn't really travel anywhere beyond a small radius around their own home or dwelling. Then, in practice, they couldn't really visit people, including those who were receiving end-of-life care. And again, this was probably an area where, and the same applied around people, attending funerals as well. And I think in retrospect, this is an area where it probably did create a lot of grief, and for some people that took some time to resolve. I should say that at the time, people were amazingly understanding of this and showed a lot of solidarity with the intent of it. Of course, looking back now, we can say probably in retrospect, now we know there are ways that these sorts of interactions can be managed more safely, and that the benefits of allowing those visits outweigh probably any potential risk.
Thank you. If we could now look at testing and transfers, I think you've touched briefly on these, but for new residents, and perhaps we can start with New Zealand, was there a required isolation period immediately following admission?
An isolation period wasn't required. Testing was required, but some facilities chose to implement an isolation period as well on top of the testing.
Okay. And did those policies evolve over time, or were they?
Yes, they did, and I think that's a key element of the development of the guidance or the policies was there was constant iteration going on as new evidence became available, and as the situation changed. It was very different if there was no community transmission compared with when we did have community transmission.
So, for example, the requirement to isolate, was that imposed later, or was it always just testing?
This was much later on in when we did have community-wide transmission especially from August 2021, and that was really just in the northern part of the country, centred around Auckland. Once we had the wide community outbreak, then there was this implementation of, or agreement to implement, the testing requirement before a resident might be moved from a hospital or from the community into a facility.
Okay, thank you. And in Sweden, Dr. Tegman, was there a required isolation period immediately following any admissions to these care homes?
As I can remember it, we had a required isolation, and I think that was to a high degree also dependent on it. Most of these places didn't really have the capacity to do that, especially the staffing that implied, because it does not only imply that you need to have a person in one room, it also needs that you have dedicated staff to this one person, and most of the care facilities couldn't handle it.
And what about testing before admission?
Yes, that was definitely required, but it was also very much done on a local level in discussion between the regional hospital and the community elderly cares. But the guidelines I talked about earlier, and I think we're up in iteration number 15 or something like that before we were over, so everything changed constantly, and especially on understanding and knowledge about what you could do with the tests and what you couldn't do with the tests. So those things changed as knowledge appeared, but they also included how many tests and what interval there needed to be before you could feel sure of that the person could not any longer be seen as infectious, because that was a big discussion in the hospitals, not only for people moving into elderly homes, but also for people moving inside the hospitals. So we had quite a lot of technical discussions on how well can you be sure about that somebody is not infectious anymore, especially for the people who had been sick for a long time with immune systems that didn't really work really very well and so on. So because it was quite tricky, especially in the beginning. Some people had negative tests for a while and then suddenly positive again. And so this really caused quite a lot of concern.
And I think in your report, Dr. Tegel, you mentioned regarding patient transfers, you note that patients were transferred between different regions. Were those care home residents, hospital patients, or both?
It was done not a lot, but it did happen, and it was mainly ICU. Okay. To optimize the use of our ICU capacity, and especially in the early days when the spread of the infection was enormously different between different regions, which meant that some regions really had a lot of capacity standing more or less empty, while other regions were overwhelmed. So a few people were moved around, not very many. I have the exact figure somewhere, but it was something. I mean, ICU physicians don't like to move patients because it's definitely not a risk-free, and it takes a lot of resources to do. So it was done in a few cases, yes.
Thank you. If we could move on then to discuss infection prevention and control measures. Apart from visiting restrictions, what IPC measures were taken to encourage the protection of residents, and which ones of those were mandatory and how were they implemented? And perhaps we can start with Dr. Tegnell.
Yeah, I mean, without going into details, we developed protocols both for hospitals and for elderly homes, who gave details about what kind of masks and how they should be used and all those kind of things. And those protocols once again were updated when new knowledge came on. But I would say that in hospitals this was not a big problem because most of these protocols were already in place for people with possible airborne transmission or respiratory diseases. And we do have in Sweden, compared to many other countries, we have a very strong infectious disease clinical group. I mean, we have infectious disease clinics, we have comparatively many infectious disease clinicians, since it's a speciality of itself, and our hospital hygiene has been, for a long time, also been very, very strong.
And we discussed a little bit about bubbles yesterday. To what extent were they used in care homes in Sweden, and if they were used, was that used for outside visitors as well?
I mean, the concept of bubbles were also in Sweden discussed, and I think many people understood that this is a good way for me to diminish the amount of contacts I have and sort of keep it within the family and not meet between families more than absolutely necessary. In care homes, I would compare bubbles to what we call cohort care.
Yep.
And this was definitely on the agenda and something we really recommended very strongly. But once again, it was quite difficult for most care homes to deliver it in a proper manner, and it was not due to the facilities but due to staffing, because a cohort means that you need to have the dedicated staff for that group of, and really made it very, very difficult for these places to keep the amount of staffing at the level that they needed to have it. So I would say that yes, some places managed to have these kind of bubbles in place, but many didn't.
If I could maybe ask you a little bit about PPE before we come on to ask. So Ashley, was PPE mandated for care home staff and for community carers or residents?
We don't really use mandates in that way in Sweden. You are supposed to follow the protocols and give care according to evidence and good practice, and that's very clear in the law. And it's up to the whoever runs the facility to see to it that happens. So if staff does not want to or doesn't care about this, once again they will be replaced. But sort of an official mandate, that concept does not exist.
And in terms of PPE, what was recommended then for use amongst care home staff and residents?
We tried to go for the same standard as we did in hospital care, but in practice that was, especially in the beginning, difficult. So whatever was available, which was unfortunate, but the only way to do it.
And we may have touched on this yesterday, but was the care sector treated akin to healthcare in terms of priority for PPE supply?
Unfortunately not, I would say, because it lives in a different system and quite often doesn't even procure these kind of things themselves, but sort of buys it from the region. So they don't really either have the systems in place to actually procure these kind of things in an effective manner, because they didn't have the relations to the industry and so on, and were also very small buyers. And that's part of the reason why eventually the national level went in and told the National Board of Health and Welfare, okay, you need to procure face masks and a few other things on the national level with big quantities, and then the system started to work better. But the system we had in place before the pandemic couldn't really handle this really enormous increase in demand.
And I think you mentioned you mentioned some examples earlier. I think what other measures were used within care home settings, for example, screens, isolation protocols, or limits on possessions were coming in or out when visits were allowed, or were those not required in Sweden?
Yeah, I mean, the protocols were quite detailed, so telling very much about what you're supposed to do if a patient or somebody living there have symptoms, telling about testing and isolations, and as far as possible, limited the amount of staff that meets them and so on. The protocols for visitors were also quite detailed, sort of clearly recommending meeting outside if possible. As I said, many care facilities also created specific places outside with these kind of screens so that people could meet and really minimize any kind of contact as much as possible. Also quite detailed advice about personnel to get tested and eventually when testing became a bit more accessible, also making quite clear that they had a priority when it came to testing, because testing was supplied by the regional level. So in the beginning this was a bit difficult because the regional level really used most of the testing for their own staff and for their own patients. And the possibilities for elderly care staff and so on to be tested was quite limited in the beginning, but that improved quite rapidly.
And if I can ask Sir Ashley then, if we could also, bubbles in care homes, to what extent were they used?
So yes, the bubble concept was very much a concept that was used in care homes to the extent possible. And just to build on the point that Dr. Tegnell has made, likewise in New Zealand, the care home workforce tends to be, the majority of them, it's a relatively low-paid workforce, quite high turnover. Many of them are recent migrants to the country. Perhaps their English is not even, which is our main language, is not even very good. So there was a big focus not just on the availability of PPE, especially when masks became available, but constant training and regular training around the use and the fitting and the use and disposal of masks, disinfection, obviously things like physical distancing where possible, not possible for the carers, but just really regular training around the protocols to help reduce the risk to residents. And yes, the idea of sort of care cohorting was good in practice, probably more possible within the hospital setting rather than in these residential care facilities.
And in terms of PPE, was it mandated for care home staff in New Zealand?
My recollection is it wasn't mandated, but there was no need for a mandate. You know, they were actively engaged in trying to secure PPE for their staff, and once we had created a national and central approach to procuring and distributing PPE, there was a requirement on the district health boards to ensure that they were also factoring in the requirements of their aged residential care facilities. So even though these were private businesses, the government stepped in and made a PPE available, especially once it became apparent how important masks were and the use of N95 masks, especially for healthcare workers and health and care workers who were in close contact with people.
So again, in terms of the type of PPE that was provided or recommended, was that similar to what was being recommended for hospitals?
Yes, it was.
And in terms of priority, in New Zealand, was the care sector treated akin to healthcare in terms of priority for PPE supply?
Yes, to the extent possible. And again, like Sweden and most other countries, the big challenge early in the pandemic was actually securing PPE. But once the supply chain was robust, then the distribution and availability was the same in my recollection for the aged residential care sector. And when I say, I should just say the residential care sector because it includes those who the facilities that were looking after disabled people. That the access was on a par with what it would be for hospitals, and likewise PPE was made available to other community-based providers as well, general practices, mental health providers, and so on. So anyone who was delivering care, whether they were public, well, they're virtually all not publicly owned, but certainly there was no distinction made in terms of ability to access PPE once it became available.
And in terms of other measures, what use was made of, for example, screens, isolation protocols, and, for example, limits on possession, such as items of comfort or religious items within care homes?
So I don't know exactly what was done in terms of use of screens. However, I imagine that there were similar use of screens and specific areas, and once we learnt about airborne transmission, use of ventilation, outside meeting where possible. I should say that, again, early in the pandemic, the received wisdom was that, and there was a lot of focus on disinfection of objects and surfaces and hand washing and use of gloves and so on. And then it became quite clear, and we certainly had a couple of examples, perhaps to the earlier question that was asked about, early on we focused probably unduly on the transmission of the virus on inanimate objects or fomites, whereas it became quite clear, and we had a couple of instances of transmission in managed isolation facilities where we assumed it was the virus on a rubbish bin or something else, but it was quite clear all it was doors being open at the same time on opposite rooms in a hotel, and an infected, the virus had been transmitted across to another room. Because we had so few infections, we were able to do very detailed investigations. And once it became clear that actually it was much more about the use of masks and physical distancing rather than this risk of transmission on objects, then the focus shifted very much away. But there was still appropriate infection prevention and control processes around disinfection and cleaning. But these would be ones that would normally be in place anyway in these facilities.
And in terms of sort of inspections or checking whether protocols were implemented within care homes, were inspections carried out, and who were they done by, and were they remote or in person?
So there are regular requirements for care facilities to be accredited, and that would be an inspection perhaps every 1, 2 or 3 years, covering a whole range of different elements of the provision of care. Our Ombudsman, which is in New Zealand, which is a parliamentary office, has a role in inspecting facilities where people are effectively there against or without an ability to leave, and so that might include prisons, and for some people in care facilities who may be in dementia level care, they might be locked facilities, and so the Ombudsman has a role in inspecting those facilities to ensure that we're complying with international conventions. And those continued with very strict attention to infection, preventing potential for infection. So those sample visits did occur right through the lockdowns as well, just to ensure that people who were in facilities where they couldn't leave were being not just appropriately cared for, but that their rights were being protected, and that we were still complying with international conventions.
Thank you. And Dr. Taylor, if I could ask you, is that the case in Sweden as well?
In Sweden, we have a special authority for supervision and inspection that does inspection in all different kind of care facilities, and they also approve, if you want to start like an elderly home and so on, they would approve you as a provider. And then you need to sign a contract with the community, of course. But we use a little bit different words, but I think the process is similar. And they don't really do regular inspections. They do inspections when there is a signal that something is wrong, and they also might do inspections when they see a more generic problem. So quite limited. So I would say that the Swedish system depends very heavily on your internal quality control systems. And there are very strict regulations about that. You need to have one in place, and that you also need to have the possibility to send a signal to the inspection authority if you see that something has gone wrong. And that's a legal requirement of all these kind of facilities. This did not, we had a number of whistleblowers during the pandemic when staff in these kind of facilities went out and said that this is definitely not right. Our facility is not living up to the standards, and they are not informing the inspection authority of that happens. So this was quite a big media thing that not everybody lived up to this. But the system is built like that very much that you have a very high level of responsibility to have a control system in place. And if you get signals that your care is not up to the standards that's given by the Public Health Authority or the National Board of Health and Welfare and so on, if that's not up to those, you need to report it to the inspection authority, and you also need to do your own evaluation and start improvement measures at once. Yeah, during the pandemic, this was maybe not really all the way there, but the inspections continued and the system kept on working, so there was no limitations to that due to the pandemic, rather the opposite. But we have a continuous discussion if the inspections are really done often enough, and if this internal quality system really works the way I think we're reasonably happy with how it works within the big hospitals, because they really take quality very, very seriously. But for some of these private providers in the elderly care sectors, sometimes not quite all the way.
Thank you. And then just before we move on to the next question about access to healthcare, so actually, if I could just ask you, to what extent, you obviously had a relatively low death rate in care homes, to what extent is that, can that be attributed to the low community transmission rather than restrictions on visiting?
Yes, so I think during the elimination phase, that was very much because we look to protect everybody, the whole population, and rapidly, if there was a community case, would rapidly go to that alert level 4, which then put in place a range of restrictions in care facilities in particular. It also gave a lot of time to prepare for when we did get our wide outbreak in the community, which didn't really happen until countrywide until Omicron came along in New Zealand, at least in early 2022. And if you look at the comparative death rate of people in care facilities, even once we had moved into that community-wide outbreak, the New Zealand death rate was about half of that of other jurisdictions like the United Kingdom and the USA. And of course, by that time we had this population was fully vaccinated, and many of them had received boosters, and we had the very strict protocols that had been iterated a number of times. So certainly there was, in both phases of the response, the measures that were in place helped protect the population within those facilities.
Thank you. In terms of access to healthcare in New Zealand, first of all, to what extent was access to healthcare restricted for residents, for example, GP visits, hospital appointments, allied health services?
So the approach across the whole system was to, where possible, deliver care remotely. And for example, just before we went, or just as we went into our first lockdown, the College of General Practitioners proposed or recommended to its members that they should aim for at least 70% of consultations to be online, and that shift was made very quickly. And then face-to-face care was reserved for situations where that was required. And this applied also, of course, for people who are in aged residential care facilities. As I mentioned earlier on, there would be GPs or nurses coming in. Actually, all of them are required to have nursing staff available anyway, qualified nursing staff available. But if there was a visit by a general practitioner, there would be protocols around that. If people required hospital-level care, then they would receive that, regardless of which part of the which part of the response we were in.
Thank you. And in Sweden, what was the case in relation to healthcare? Was it restricted in terms of GP visits, hospital appointments, and allied healthcare services? And this is for people within residential care and. Not
restricted in that sense, but prioritized, I would say. So some elective procedures, I think we talked about it yesterday, were postponed especially because intensive care places were not really present, and you need to have that in the background for quite a lot of those kind of procedures. This is normally what occupies most of our intensive care units. Not everybody knows that, but this is what it's all about. So priorities like that, of course, made that some people had to wait longer for those kind of procedures. But otherwise, no restrictions, I would say. It was really, I mean, the signals were really to deliver care as much as possible. Remotely, very much so. And this is something that in Sweden, with the big distances in parts of the country, already to a certain extent has taken place. And we have quite a lot of also private providers of remote care. So there's quite a lot of experience in that field. So I think that primary care felt less of a pressure than normally, but this was more due to the people were slightly scared of going to the health facilities because they really felt that this is the place where I might get infected. So primary care had less visitors than normally. But I mean, everybody who needed care definitely got care, and there was never any question about that. And I think also when we try to follow up afterwards, I talked, for example, among people in charge of our quite extensive programs for cancer prevention and so on, and they say that when it comes to breast cancer and so on, the number of people coming for checkups and so on remain basically the same as before. So even if they had a lot of procedures in place to avoid meeting many people. So, and I think also afterwards, when we look at the outcome of many health conditions, that in general it seems like the system kept on delivering healthcare more or less to the same level as before. The heart doctors in Sweden say that they see a slight tendency to more people coming in with heart failures. And they think that people to a certain extent avoided going to care when they had chest pain, especially during the first spring. And that maybe some cardiac problems that could have been treated early on were missed. Not because there were restrictions, but people did not really like to go to hospital. So slight tendency in that, but otherwise we don't have any signals that the treatment for NCDs in general did not keep the quality that it has had. And I think also what we've seen in Sweden, that the average lifespan and so on has very quickly gone back to the same curve that we had before, also says that no, we don't really have a problem with that. Personally, I think that a considerable amount of the excess deaths that we see in many countries is not due to COVID only, but also due to that many of the NCDs did not get the kind of treatment that they normally would have done.
Excuse me.
Yes.
If you don't mind, can I just make a correction to my earlier comment? Now that I've reminded myself, looking at my submission, actually I was confusing two figures. Our peak hospital admission rate was half of what it was in other comparative jurisdictions at the height of our community outbreak. And actually the report of our first phase of our inquiry found, and I quote, New Zealand recorded very few COVID-19 deaths amongst people living in residential care, residential facilities such as aged care homes. So the high vaccination rates and the protocols, even once we had a community outbreak, meant that we had a small number of outbreaks inside those facilities and a small number of COVID-related deaths.
Great. And if I could then ask you first, so Ashley, if we can move on just to the final topic under this heading, how does New Zealand normally approach orders for do not attempt CPR in ordinary circumstances, and whether and to what extent that differed during the pandemic? And I'm referring specifically in relation to orders used within care homes and homes for people with PIMD, and also hospital settings for maybe vulnerable people within those settings at that time.
Yes, so we would call these a DNR, do not resuscitate order, or probably a better word is agreement, and that's something that's done in discussion with the person themselves and their family. And if it's someone who may not have the cognitive ability to make that decision, then it's done very much with the family. And because of the approach we took, we didn't need to make any changes to that protocol. And this tends to go hand in hand with EPOA, enduring power of attorney, which is again an agreement with the family and a care provider, or in the case of EPOA would be with a lawyer. So no changes to that approach. It's very much a consent-based approach.
Thank you. And Dr. Tegnell, in Sweden, what is the normal approach, and how was it applied during the pandemic?
No, it is the same. There's very strict protocols in place, very strict obligations to the doctor who decides on this to have a close dialogue both with the patient when possible and with the relatives. So that's definitely something that's very strong and also discussed quite often, and the inspection also goes in and look at this. I think in hospitals it works normally very well. In these elderly care homes, it becomes a bit more complicated in many ways, because it's many of them don't really have the cognitive abilities to really understand what it's all about. The level of doctors actually being present is much lower than the thing you have in New Zealand. So even if officially there is a primary care physician in charge of the facility, they normally don't come very often and so on. So there it often, I think the impression was that it felt quite shaky, and not really so much about CPR per se, but more about the discussion around should these people be transferred to hospital care and ICU care. I think that's where we had a big discussion. Is it relevant to move somebody into intensive care? And this is, of course, a continuous discussion always, because intensive care is always a limited resource, and you also need to understand that to get some benefits from intensive care, you need to be fairly healthy. So if you're very old and frail, intensive care tends to just extend the suffering. And to have that understanding and to get that understanding, and especially to apply that to people living in elderly care homes where they didn't really have a regular doctor that knew very much about them, I think that's where we had quite a lot of discussion. And, so that's really something we need to think more about and discuss more. It's not CPR, because I think that's easier.
Yeah.
But this discussion around should you get the benefit of intensive care or not, or should you be moved into intensive care or not? I think that was very heavily discussed, and there also came out some kind of protocols from one of the regional jurisdictions saying that people from elderly care homes should not be moved into ICUs at all, which of course is completely wrong. You can never take that decision on that kind of level. You need to do it by individual. So this was also ended up in media, and they had to withdraw it, of course, at once. But yeah, it caused tension, and especially since these places are not very well manned by medical professionals.
Thank you very much. Is that very recorded? Okay. My Lord, I think we've reached the end of the session.
Very good. We'll come back at 11 o'clock. Thank you. Right, when you're ready, Miss van der Westerhuizen.
Thank you, my lord. Next topic is relates to education, and I think we'll probably start with New Zealand on this one. So actually, when and why were schools, early learning centres and further and higher education institutions closed in New Zealand, and was there a move to remote or online learning?
Thank you. Yes, so this first happened when we went into the first lockdown in March 2020, and in Alert Level 4, all educational institutions closed, and children were provided with opportunities, and this was established very quickly for distance learning, and there were significant efforts made to support this, including distribution of devices out through schools to households for families who might not have them. There were facilities, the facilitation of teachers being able to undertake online teaching for periods each day. And there was even a dedicated sort of TV channel set up with educational programs for children. For some students, especially international students or domestic students who were in boarding facilities or at tertiary hostels who couldn't get home, then there was provision for them to stay where they were. The accommodation could remain open, but otherwise people had to go home and be in their bubble. Once we started moving out of the full lockdown into Alert Level 3, then these educational facilities would open up again, in particular early learning centres in schools for children up to what's called Year 10, which is about age 14 or 15, but the more senior years at secondary school, they were still working and learning from home. Again, students were encouraged to stay home if they could, if they were in those age groups, but schools were open, and particularly where parents might be essential workers and both having to go out to work, then those children could go to school, and the facilities were open for them to do that. The longest period of time that schools and educational facilities were closed was during that first lockdown. The other two small community outbreaks we had in August 2020 and February 2021. There was a very short period of time when they were shut, but then later in 2021, when there was a longer outbreak in the Auckland region, then they were again children were learning from home. But by this point, there were quite good. There was good facilitation of online learning to the extent possible for students.
And that facilitation of online learning, how was that delivered? Was that delivered by the individual schools, or was there a national approach? Or
so it was individual teaching staff really, and the schools would facilitate it, but teachers were essentially engaging with their classes online. Now, obviously not ideal, and none of them had done that before, so it was an extraordinary effort to be able to do this, and it was generally for short periods each day. So, one of the challenges, of course, was that you had parents or caregivers who were still, many of them, if they were at home, they were still working from home. Many of them, they were also trying to look after and educate children. So it created a very stressful milieu for those families. But there were these other television programs and so on that were designed to and intended to help with maintaining children's education through the period.
And what was required or recommended at various stages in terms of working from home? Just in general terms, what was recommended?
Well, in lockdowns, everybody who could had to, work from home unless they were an essential worker and had a special permission, essentially, to go into their workplace.
And so, was any specific provision made for parents, for example, having to cope with children at home and with sort of remote or online schooling?
Well, only in the sense that people had the opportunity to organise their bubble in a way that that might support that, either by having other family members into the bubble to help with childcare. Of course, there was enormous flexibility shown as well from workplaces to ensure that people could balance these responsibilities. And there wasn't an expectation that children would be educated from 9 in the morning till 3 in the afternoon. So there was, I think families and households showed enormous adaptability to be able to cope with this situation.
And was there any particular guidance given to parents to cope with children trying to learn from home?
Well, again, this is something where I think informal networks were fantastic, and people shared ideas with each other. There was, we were very fortunate in New Zealand that we had amazingly good weather during the first 2 months of that first lockdown, so people could get outside, and there were just, I think I mentioned yesterday that there were a lot of families who would be out walking and or biking and spending time together. And for many of those families, the feedback you get is actually it was quite a special and precious time for them, that they actually ended up spending more time together than they usually would, and not having to do all the usual busy activities that they might usually do was, for some, a real blessing. So there was plenty of informal exchange of information going on. And neighbourhoods were supporting, I guess, families to be able to cope with this really unique situation.
Thank you. And if we can just rewind slightly, I think from May 2022, there was a phased return to in-person learning for ELC in schools. How was that phased return managed, and what precautions were put in place, for example, within schools and ELCs? Bubbles, social distancing, screens, masks, ventilation and outbreak protocols, just to name but a few.
Yes, so if we go through to the start of 2022, that's when we had our first big community outbreak, the Omicron outbreak. So going into that outbreak, there were strict protocols. By this point in time, we had moved from our elimination phase into the sort of a mitigation phase, and we were on our traffic light system. So there was clear guidance given to educational institutions about requirements on them for ensuring children were symptom-free when they came to school, and parents as well. Use physical distancing when possible. Children from above year 4, so from about 10 and upwards, were required to wear masks at school, as were teaching staff. There were efforts put in to ensure that there were not assemblies or gatherings of lots of children inside. A lot of outdoor activities. There'd been a lot of work gone into supporting schools with air circulation, air filtration, if they couldn't use natural airflow in their school settings, and there were requirements on them if they did have an outbreak in a school, that they then did have to actually test the children who were close contacts to find out what was going on, and potentially, so for the first 3 days, and then potentially stay shut for up to 14 days. But that was more on a school-by-school basis, depending on whether or not they had a lot of children and or teaching staff who were infected with COVID. And very often it was actually teaching staff being infected that meant that schools, or at least classrooms, had to, classrooms of children could not come to school. So that was a challenging period through that community outbreak.
Thank you. And that was, I think you mentioned that was 2022. What about the earlier phased return to school? Were those sort of measures in place as well?
Yes.
May 2020.
Yes. So going back to 2020, yes, there was the stepping down through but quite quickly through the lower stages of the alert levels, and just, again, the implementation of, in fact, it was more about who could access the facilities to help reduce the risk rather than use of masks or other protocols at that point in time, because we didn't start moving down through the alert levels until we were quite confident. We had a high level of confidence there wasn't actually community spread still happening, and then we were able to move down quite quickly. But this is all laid out in detail in the alert level framework, just what was required in education settings, and it differed but from early childhood education through to tertiary education.
Thank you. And in terms of effectiveness of measures, and it may be impossible to say, but to what extent was working from home as a measure effective in reducing the spread, or is it impossible to say?
Well, it was part of, it wasn't so much the working from home, it was the requiring people to limit their exposure to others and limit their travel that, of course, was the key in terms of breaking the chains of transmission that we had at the time in the community, and then getting our number of cases down to zero and being able to then move into that elimination approach.
And similarly with school closures, to what extent were they effective in reducing the spread, or again, is that part of it?
Well, they were part of that broader approach. And in New Zealand, of course, and we may well come to this, there have been reviews of just the negative impacts too of school closures and the disruption to children's learning, children and young people who might have been at tertiary level. But at the time, they were part of really that community-wide approach to just really confine people to their bubble. And limit the extent of their travel and exposure to other people.
Thank you. And in terms of risk of infection, what was the risk of infection for those, or assessed to being for those working within schools and colleges in New Zealand?
Well, one of the things we found after we'd had our big community outbreak was that actually our school teachers was the occupational group with the highest rate of infections. So that was quite interesting, I think perhaps different from Sweden. Now that may reflect that we had relatively low rates in other groups, or it may just reflect the fact that they were exposed to more likely to be exposed to children who were infected. And again, this was our first wave. By this time, of course, many of the children and school teachers were required to be vaccinated by this time. So part of the rationale for closing and restricting educational settings, in particular schools, was not so much the risk to the children, but just the fact that there would be a lot of low-grade infection or of each other happening, and then it was infection of school teachers and of other family members that was a key concern there. And
in terms of post-viral sequelae, or what later became known in some jurisdictions as long COVID, how did the rates of those infections for teachers and staff compare to other occupations in New Zealand?
I don't have any information about that, and I'm not sure that information would be collected for people who have got ongoing post-viral symptoms. One of the things I can say is all the studies that I have seen subsequent, that are still being published, do show that vaccination is protective against both having long COVID or symptoms, let's call them long COVID symptoms, and there's a huge array of symptoms, and the intensity and the duration of those symptoms. So that's one thing we do know. So again, one of the perhaps unintended but positive outcomes of us deferring our community outbreak, A, until it was Omicron, and B, until the vast majority of people were vaccinated, is we're likely to have a lower burden of long COVID within the population, and of course that would apply particularly to those groups that might have had a higher rate of infection, occupational or other groups.
Okay, thank you. And you touched on there briefly the impact of school closures. Could I ask you just briefly to outline what those were, both for children and parents and also staff?
Well, it was challenging, and if you look at the report of the first phase of our inquiry, there's some verbatim feedback from school teachers and parents and even children who were interviewed or who made submissions as part of the inquiry. Now, some of those submissions are positive about what happened. Others felt that things could have been done better, and that also the disruption to learning was the most significant negative outcome. And I think this is something that's seen globally. Of course, it's hard to distinguish between how much of that was due to the school closures per se and how much of that was due to the fact we were experiencing a global pandemic which disrupted every aspect of our lives, and regardless of whether schools were closed or not, was extremely disruptive. It's extremely disruptive for children to have parents or grandparents or other relatives become extremely sick and or die from a disease as well. So we in New Zealand were able to avoid that aspect of the disruption, but the trade-off was that for children their education was disrupted. I should also say that because of our use of lockdowns being early and intense, they were relatively shorter than the lockdowns in many other jurisdictions. And so actually the amount of time that our children had out of school was much lower than in other countries that perhaps didn't take an elimination approach. And talking to people who were perhaps living in the US at the time, it was not unusual in some states for children to be out of school for a year. And so that was clearly much more disruptive. I should say one of the things we've found, and I'm not sure if this is the same in other countries, but we've got a higher absentee rate still than we had pre-COVID. And part of this was parents who wanted to keep their children out of school because they were worried about them getting infected. And we've got about twice the rate of homeschooling now as we had pre-COVID. And some of this may be that parents found they enjoyed the experience, but I think a lot of it is just that there is still a residual concern about the potential exposure of their children to COVID, and or this may be also some groups because of the vaccine, their opposition to vaccination, have decided to continue homeschooling their children. But we're still not seeing the same attendance rates at school as we had pre-COVID, and it's climbing, but it is taking some time to climb back up. So that's a longer-term sequelae.
And in terms of educational impacts, but in the broader sense, beyond just learning, and probably feeds into public health, have there been any notable challenges to mental health and well-being in relation to children and young people as a consequence, or that can be attributed to school closures? And social aspects as well, impacts on so.
I haven't seen any studies on this. New Zealand, like I think virtually every other high-income countries, has seen an increase in the incidence of mental health symptoms, in particular anxiety amongst children and young people over the last decade or so. Now, there's a lot written about what might be driving that, including perhaps a link to social media and constant use of devices. But of course, it's hard to tease out what might be due to the closure of educational facilities from the fact of a pandemic and these other factors that might be operating in the background. What I can say is also that after the very significant earthquake we had in Christchurch in 2011, which was an extremely disruptive event, the earthquake itself and the ongoing aftershocks, there was documented deterioration in children's mental health and increased anxiety, which is seen after these sort of major events, and that takes years to come through, and in fact it tends to impact a sort of a whole generation of children. I have no doubt that the pandemic per se has had a similar impact to some extent or other on our children in New Zealand, and I suspect in other countries as well, but it's very difficult to tease out just what exactly is due to the pandemic per se, other factors that might have been in operation, like exposure to an increased use of devices and social media, and of course the specific impact of school closures per se.
Thank you very much. Dr. Tegenall, it was quite different in Sweden. Schools remained open for children up to 15. Could you please explain what IPC measures were in place in schools at the time, if any, for example, bubbles, distancing, masks, or ventilation measures?
We gave quite detailed, and once again we had a working group working on that, seeing what kind of IPC measures are possible in schools and how they could be used. And the schools worked very much with trying to avoid big gatherings, so the morning gatherings and so on that sometimes took place before were not in place anymore. They also tried to spread out the school day, so not all the children were not there at the same time. We don't usually do that in Sweden, but now we did it. And sort of altogether diminish the contacts as much as possible within the school setting, not having lunch at the same time and all. Yeah, all of these kind of things you can do while keeping the schools and the curriculum running.
And were schools closed for under 15s in the event of any outbreaks or spikes?
Yeah, I mean, it happened that school closed for a few days, maybe a week sometimes. Then, in a combination with also that so many people were actually sick, especially among the staff, that you couldn't really run the school in a normal manner anymore, and also to break the transmission within the school. So that did happen, and in close collaboration with a local communicable disease officer in the region. Those kind of, but the decisions were taken by the dean, or the, what do you call it in English, the head of the school. Yeah.
And for over 16s, they were required to do distance learning for a few months at 2 stages, which I understand was until September 2020 and from December 2020, unless they had training that could be done or that could only be done in person, for example, vocational training. How was distance learning managed during those? For the rest who were required to do distance learning?
It was done by the schools, I think in a very similar manner to what happened in New Zealand. And the teachers basically set up the training in a similar manner they would have done with the pupils in the classrooms. So it was done on Teams or any Zoom or any of these kind of sites. And fortunately in Sweden, people are to a great extent on even fiber, so they have very fast internet in almost all places, even out in the remote areas of Sweden. And computers have, in different programs in Sweden, been subsidized by the state, so access to computers and so on is very, very high. And when that did not work, the schools also supplied the students with them. So that transition, as far as we can understand afterwards, went fairly smoothly. The teachers were not happy because it's not optimal, but I think what we can gather from the school results afterwards in those age groups, school results did not deteriorate noticeably. And that cutoff was made partly because it is a normal cutoff in the Swedish school system. We have the first 9 years as a basic schooling, and then you go into what we call a high school, which is then voluntary, while the first 9 years is compulsory. Homeschooling is not allowed. So it was a natural cut, but it was also a cut where we did start to see that at least some children start to get sick, but also that the school authorities told us, okay, about that age, we believe that most students will be able to benefit from a distance learning in a similar manner that they would to an in-person learning.
And that probably ties into the next question. What was the rationale for how schools and colleges were dealt with in Sweden? In other words, for keeping younger children in school and allowing older children to online learning or distance learning?
I mean, we have had this discussion in Sweden before, during our pandemic planning. We had a very intense discussion around what do we do about schools during a pandemic, not least because many countries, especially in Asia, tend to close schools during flu outbreaks and so on. And I think they see some kind of effects of that. And I think that generally children are seen as kind of an engine in flu outbreaks quite often. So it's a different kind of concept. But still, we didn't really see that the benefits were all that great even then, and we had concerns then we went through what the possible effects were in different ways. I mean, one of the effects would be that we would lose a significant amount of people working, especially in hospitals. I mean, you need to remember that in Sweden, both parents usually work, and also tend to work in similar places. So if one of the parents work in hospital care, the other one also works in hospital care. So we could calculate, because of all our registers, we could calculate that
Dr. Taylor,
hospital
sorry,
services.
Interrupt you there. I've been told that I need to ask you to slow down slightly. It's being transcribed, so
Okay,
they're not managing to catch everything, all this valuable information. So if I could ask you just to slow down a little bit, please.
I'll try to. It's probably a sign that I've talked about this too many times. We could calculate that hospitals might lose up to 20% of their staff, which would have significant effects on during a pandemic. When we also went back to this in the start of the pandemic and had very intense discussions with school authorities and so on, we really saw that school closures would have immense effects, especially among the children already at disadvantage. And that group is a significant group in Sweden and not really something to take lightly. And we could also see from the figures from China and other countries, and also from Sweden very early on, that children very rarely got ill. I mean, the children that needed hospital treatment were extremely few. And when we did prevalence studies and so on, they didn't even get infected very much. And this was in the early days. I think Omicron was very different. And I think that's one of the reasons why you see the high level of among teachers in New Zealand, because that was during Omicron, who had a completely different profile, infected children a lot more, and was a lot more infectious. But in the early days, children were definitely not the engine in the pandemic, rather the opposite. So any kind of argument for closing the schools and having an effect on the spread of the disease, we didn't really see them as very, very strong. But the arguments for keeping them open and providing the children with knowledge, social interaction, and especially the disadvantaged children, were very, very strong. And we had intense discussions with school authorities and with teachers and so on. But in the end, I think, especially when it sort of all started up, we had a huge agreement among teachers and others that this was really something we did that was very useful. And we also did comparative studies with our Nordic countries that did close schools for extensive amount of times. And we tried to see if this affected the spread in the community in any manner in those countries. And no, we cannot really see that. And we still talking early, during the first year or so of the pandemic. So I think there's sort of consensus, at least in the Nordic setting, that keeping schools open was probably a good choice.
And just in terms of remote learning for over 15s, in terms of educational outcomes, how effective was that, or how successful was that?
No, it's from the, I mean, we do have national tests and so on, and we can't really see that there was any deterioration in that. When we get up to university level, many universities in Sweden already have extensive program for distance learning due to our long distances sometimes and so on. So this was not a very difficult transition for them, because they had most of those things in place, and they had all different kind of learning platforms and so on that was already used extensively. So for those groups, it was more a social thing that many people move away from their home and live in student quarters and so on, and got quite isolated. And that, I think, is the remaining problem. Just on the sideline, we do see the same trend in Sweden as you do in many countries among younger people, that mental, at least the way reported mental health is increased. There's many discussions if this is due to that young children these days are more open about it and can talk about it, and that I'm quite sure that part of it is there. But there is also other things going on. And we have been following those curves, and the curve during and after the pandemic remains the same. It's a slight increase every year. It did not, during the pandemic, did not change anything. I don't have the details here, but I know that there has been studies in other European countries with extensive long school closures, and that has really increased the level of mental ill health in those countries. So I think there is quite a strong connection. But I think, as my colleague said, that it is very much depending on how long and what kind of things you put in place to alleviate. So there are many aspects to it. I think there's quite extensive reports from poorer countries that closing schools was really very, very harmful, with girls not coming back to schools, forced into marriage, and teenage pregnancy on the increase and so on. So, as many other things, it's very much about context. Absolutely. If you have a good context, you can probably close schools for at least limited amount of times without too many ill effects. But if you don't have those compensatory mechanisms in place, school closures will lead to very bad results in many places.
Thank you. I think you've probably answered this yesterday, but if I could just ask you again in the context of this discussion, how did Swedish authorities work with unions in relation to keeping schools open? And related to that, what was the risk of infection for those working in schools or at colleges as well?
No, we could, since we have all of these registers, we could follow quite closely how different occupational groups were affected. And it was quite clear that the occupational groups that could not work from home did get infected more among those teachers. But teachers were at the same level as bus drivers or any other kind of group that needed to be out in society to work, because it was an essential service that could not be performed in any other way. And there were, we had a lot of dialogue, so there was also quite a lot of understanding around this, and also that we could show that very rarely any of these people really got severely ill, even if it did happen, because they were most of them young and fairly healthy, so it was not all that dangerous. But still, there was intense discussion because the occupational safety laws in Sweden are very stringent. So there were some concern among bus drivers and also other groups at some time that their protection was not really as high as it should be, even if we could show that it was very uncommon for them to get severely ill. And I think this balance between occupational health laws and the needs, the things you need to do to keep the society running is a discussion that we have ongoing, because it's not completely easy, especially when the occupational laws are as strict as they are in Sweden, who really gives the employer a very high level of responsibility to keep the employees from any kind of increased harm. So that we had quite intense discussion between the different agencies, the Occupational Health Agency and us. What can we possibly do during a pandemic? Don't we need to sort of, to a certain extent, accept that we cannot really fulfill all our obligations during a pandemic? And in their system, then no, there is no way out of that. You always need to supply the highest level of protection.
And just the final question, how did rates of post-viral sequelae or long COVID for school staff compare to other groups? And again, I think this is something possibly you've touched on yesterday.
I haven't seen anybody doing that. All the studies I've seen, there is a number of risk factors for long COVID, but I haven't seen that occupation is one of them in any of the studies I've seen so far. But it's, I'm not sure if anybody run those yet. It seems to. Yeah, it's clearly connected to when you were infected, because the earlier on in the pandemic, the higher the risk. It also depends very much if you were vaccinated before or not, or if it was the first time or the second time. So there's those kind of things that play in. But So it probably has more to do with the incidence and prevalence in a specific occupational group than anything else, I would say. So it's clearly connected to that. So I wouldn't expect teachers to have long COVID any more than any other occupational group that also were out in the society.
Thank you very much. Our final theme, and I know it's one that you were both very closely involved in, is communication and public health messaging. And I'm, in our 25 minutes left for the session, hoping to cover general communication strategy and delivery, modes of communications and audiences, misinformation and disinformation handling, and engagement and impact. And if I could perhaps start first with you, Sir Ashley, in relation to general communication strategy and delivery, could you please give an overview of how this was structured, including the aims? Was it persuading, compliance, or providing data or information, and also indicate who delivered the key messages and the role of politicians versus public health experts?
Thank you. And I mentioned a little bit about this yesterday, that at the start of the pandemic, the Ministry of Health was essentially responsible for providing regular updates and answering media questions, and myself, plus or minus a colleague, would do started doing a daily media briefing. As things escalated, that changed into a joint briefing between myself or the Director of Public Health with a senior politician, and often the Prime Minister, especially once we went into lockdowns. The role of these daily public communications, televised, broadcast, was absolutely fundamental. And this approach of a politician plus a senior official or a technical person was one that was in common with many countries. Perhaps Dr. Tegnell, a different experience there, as I'm sure he'll elaborate on. But this proved to be, for New Zealand at least, a very effective way of getting the messaging out there. And as I think I mentioned yesterday, that the 1 o'clock briefings became sort of appointment viewing, probably because we had confined people to home and they didn't have too much else to do. And there was a standing joke that if you wanted to do your supermarket shopping, the best time was to go at 1 o'clock, because then the queues were the shortest. The other important thing that happened was quite early on, by March 2020, we had established a dedicated all-of-government National Public Information Management team in the National Crisis Management Centre. So it had moved, the responsibility had moved away from being the Ministry of Health per se to being an all-of-government function. And there was extensive collateral developed which was themed, and I've got actually a book that's been subsequently written, but this yellow will be and black will be instantly recognisable to any New Zealander, because all this theming was a feature of all the communications and the collateral, and this very distinctive message around unite against COVID-19 was one that underpinned a huge amount of information that was put out to the public. And there have been independent assessments done of the effectiveness of that communication, the whole effort, and in particular the 1 o'clock or the regular public briefings. But the most important element here, and I often describe this as our most significant public health intervention, was its role in building public trust and confidence in the response. And it doesn't matter what the response was, but if people had confidence and trust that the response was reasonable, that it was in people's best interests, then they were much more likely to do what was being asked of them. And I mentioned yesterday the high level of public trust we had with regular surveys through the first lockdown, suggesting over 90% of the public had trust and confidence in the government's response, a result that clearly transcends political affiliations. It certainly transcended gender and ethnic boundaries. So very high penetration and effectiveness and awareness of the campaign. And that was, again, I think a critical part of our overall success in being able to implement and maintain an elimination approach for so long.
Thank you. And if I could ask you, your public information management team, to what extent do you know whether they shared information and strategies with similarly purposed teams in other countries?
Well, I know they were, like all of us across our government anyway, were looking avidly at what was happening in other countries and jurisdictions to see what was working there. And I know, whilst the collateral was very much focused on the New Zealand context and also segmented for different New Zealand population groups, whether by age or ethnicity or recent immigrants or whatever it might be. But I know they were drawing on what was being done in other countries. And I haven't mentioned it yet, but I just do want, it's a good point to make, time to make the point that we were working extremely closely with Australia. There's a lot of rivalry on the sporting field, but in this case there was, an enormous amount of cooperation from Prime Minister level right down, and we were on daily technical meetings with our counterparts in Australia, a lot of sharing of information to ensure that we were, in step and also supporting each other's efforts.
And just if I could ask you again, and something you touched on yesterday, the modes of communication used. What use was made of, for example, you've mentioned the daily briefings, government websites, social media, and mentioned there the accessibility of information that you steps made, but how accessible was information for those with disabilities, for example, visual and auditory impairments, those with English as a second language?
Very specific efforts to ensure that all population groups were able to access the information. So yes, accessible presentation of the information for visually impaired people or for the deaf community. There was a lot of effort to translate into a range of languages some of the key artefacts. And the other thing we did, and that I and colleagues were personally involved in, was meetings with key community leaders or groups of, particularly from ethnic minority groups. There might be church leaders, iwi or Māori leaders I've talked about, Pacific church leaders. The churches play a very significant role in the Pacific community in New Zealand, but also youth constituencies, which had their own particular style of Zoom meetings. So myself and colleagues would attend these online meetings really so that we could answer their questions, tell them the key messages, and they could then repackage them and spread them out through their channels to their various communities to make sure that the key messages were getting out. And it's also an excellent way for us to get feedback to understand what the particular needs might have been of communities. So that was a really important part of the overall approach.
So those Zoom engagements you mentioned there, did you mention there, I might have misheard, also with children and young people, groups representing children and young people?
Particularly youth, so more teens and young adults, and making sure that they had the opportunity to ask questions that they might be hearing, because they're of course very, very networked into their communities, but really effective way of getting the messages out. And also to communities that might not necessarily have had a high degree of trust in the government, so to inform leaders or people who those communities might trust, and let them get those messages out in the way that actually would resonate with their communities.
Thank you very much. And Dr. Tegnell, if I could now turn to you on your Sweden's General Communication Strategy and Delivery, and again, how that was structured and what the aims were, persuading compliance or providing data and information, who delivered the key messages, and the roles of politicians versus public health experts. And I know you've touched on some of this already yesterday.
Yeah, I mean, it's a big area and we could talk about it for a long time, but maybe I should start with saying that the Public Health Agency in its mandate and traditionally did not really communicate with the public. It was not sort of something we were asked and supposed to do, but rather that role was given to the communities and to the regions who has this sort of operational responsibility. So normally we would develop knowledge and even messages, and they were given primarily to the regions, and the regions would use them in different ways and so on. So but what happened this time was that didn't really work because it would have taken too much time and it would be too much of a time lag and so on. So quite early on, in spite of that, it was not normally what we did. We started this daily press briefings, televised and so on, which became incredibly popular. I think we had 3-4 million viewers on something that was incredibly boring. So that was quite interesting. And it's also important to understand that we were actually asked to do this by the political level. We had run a few and we were more or less saying, okay, now we've done that, let's somebody else do it. But then our Minister of Health came to us and gave us officially to do this kind of daily press briefing together with the other major agencies, which was the National Board of Health and Welfare, who took care of the hospitals, and the contingency agency, MSB, who took care of the civil preparedness. So then we stood there together for, as I said, 198 times. So it was a major effort in many ways, but also, I think, extremely useful and I think very insightful of our politicians to understand how important this was. And we really divided up the communications in 2 blocks. Technical communication was done by the 3 of us. The political communication, when the politicians had been involved or needed to be involved or needed to reinforce something, they did their own press briefings together with the directors of the different agencies. So it was a clear division, not standing beside each other, but a clear division. And also at the political level, they had a fair number, not as many, but I think 40, 50 or some press briefings doing this. So it was not an uncommon that we had both press briefings, first one at our place at 2 o'clock and then one at 4 o'clock in the government offices. And as I said, it proved incredibly valuable in many ways. And I think it also comes back to what in Sweden has become very, very important, and that's transparency and openness, which meant that all the data was always available to everybody. Had interesting side effects that many use this data to do completely new kind of analysis that we never even thought were possible to do. So it's giving out data like that has some interesting effects. But it was very much about that, and it also meant that we had to employ a team of, I think, 5 or 10 different lawyers just looking at everything that the media and everybody asked for us to give out, because, of course, everything was public, that could be public, but individual data and so on were not allowed to be public, so we need to scan everything. So this also cost an enormous amount of work for the agency to be as transparent as we were supposed to be. And we worked very hard on that, but never really managed to keep up, because it's supposed to be speedy. When you have hundreds of demands every day on extensive, I mean, sometimes they ask for all the emails that came out of my account, and during the first year I had 40,000 emails coming into my account. So and then all of those had to be scanned, so that no personal information happened to. So there were side effects to this, but on the whole, it was very successful, very appreciated in many ways. The one thing we struggled with was, you also talked briefly about that, was to reach all different kind of communities. They're more complicated in Sweden because it's a lot more heterogeneous. We have, I mean, there are schools in Sweden where they have like 20, 30 different languages. Wow. So our migrant group, which is 20-25% of the population, comes from a wide range of different countries, different cultural background, different languages. So this was an enormous challenge. We did not really, we worked very much with it. We worked very much with it together with the regions and the communities, but still. And also because integration of those groups in Sweden has not really become as successful as it should have been. So there's many backgrounds to that, of course. But it was really a challenge. And on top of that, many of these groups relied heavily on information in social media from their home countries. which was not always the same kind of information that we gave in Sweden. So there was many reasons why those groups did not, even if we translated them, I don't know how many different languages, we did all of this kind of normal things. This remains a problem, how to reach these groups. And we have afterwards worked quite a lot with trying to find peers in those groups that can work as kind of translators into those groups, which seems to be working reasonably well. So that's what's the big challenge, to reach the sort of majority of the population through media and so on. That worked, and people were quite pleased about it too, and I mean, really.
And specifically, children and young people and people with disabilities. You've touched on how to reach groups. What about children and young people?
Yeah, I mean, we also try to design specific communications with them, and I and other people also appeared, and we have a special news programs for children where one of my really interesting experiences to come and talk in those kinds of newscasts that they did. So we also try to reach them and also through social media in different ways to adapt. And there is already a law in place in Sweden saying that everything we put on our web needs to be adapted so that people who have different kind of disabilities can also access them. So and that applied, and we adapted. So for people with difficulty in reading, you could click on it and everything would be read up. So all of those kind of things are in place all the time, and so we work quite a lot with that for many years in trying to do that, because translating tables and curves into a speaking voice takes some
challenging.
Yeah, but those things were in place. So I would say that to the extent that it is possible to reach those groups, we did as much as we could.
And just in relation to misinformation and disinformation, what was the nature and extent of that? I think you'd both touched on yesterday there were some issues in relation to vaccine uptake, and were there any other issues, or what was the nature and extent of the vaccination issue, and how was this tackled? I can start with you.
So perhaps if I can start here. So the term I now favour for mis and disinformation is, I think, a useful one, which is harmful, inaccurate information. As it's sort of less loaded and is really what I think the problem is. So this started to appear very early on in the pandemic, of course, particularly related to whether or not the virus was actually a serious problem or not, or if it was just all a conspiracy. So conspiracy theories started early on and really accelerated once vaccination, once the vaccines were available and vaccine programs started. And actually a recent study has shown that New Zealanders were exposed to more of this misinformation online than in other countries. And we know a lot of it was being generated by a relatively small number of actors, including some of it state-sponsored. I often get asked, how do you did we deal with that harmful, inaccurate information? Actually, the gift of having a 1 o'clock stand-up every day was by far the most important response, because what we found is that the vast majority of the population, of course, are very discerning, and they are able to make a judgment themselves about the accuracy and value of information they're hearing. So rather than responding or reacting per se to the mis and disinformation, it just reinforced the key planks of our communication approach, which was absolute consistency of messaging, getting feedback around which messages were or were not resonating with different groups and adjusting the messaging, doing very, very careful preparation, occasionally addressing specific mis or disinformation that might be circulating, but mostly just providing through every possible channel the best possible accurate information for people to access. And if we think even in the case of vaccination, which is the area of the response where there was the highest volume of harmful, inaccurate information, in New Zealand and many other countries, they were still able to achieve over 90% vaccination rates, which suggests that the vast majority of people were persuaded by the official information that was coming out.
Thank you. And Dr. Tegnell, what was the position in Sweden in relation to the nature and extent of, I'm going to call it, harmful and inaccurate information, and how this was tackled?
No, I mean, this is a global phenomenon, so I think this exists all over the place. And I think the differences may be mainly in what kind of uptake it sort of has. And I think that comes back to trust that we discussed. If you have a high level of trust and so on, then you can get past that. And I think our basic strategy was very similar. And we learned that from the vaccine area, where we had worked extensively with this kind of misinformation before, and talked to different kind of experts that gave a very clear advice about do not go into communication with the people who said that this is dangerous and so on, but try to make available good information in your trusted channels. And we kept on working like that. I would say we did cannot really remember an instance where we actually went out and said something about faulty information out there, but generally we just supplied what we considered was the best information available at any given time, and that was really the strong strategy that we had. Of course, we had people that kept on scanning the social media and so on to try to understand what's going on, so that we could see that if some kind of strange information was appearing, that we could sort of come out with the correct information in the same kind of area. So it was not that we ignored it, but more that we tried to sort of compensate for it, and also use social media very much for trying to understand what are the major questions for people at large during this time. What do they want to know? What do they need to know? So that we could supply that kind of information very clearly to them.
I see we have 3 minutes left till we break for lunch. So if I could possibly ask you, just finally, to end with getting your views on the extent to which levels of compliance within your respective countries was attributable to your respective communication strategies. So if I could start with you, Sir Ashley, again.
Well, I've alluded to this, but there was very high penetration awareness of the communication and the messages. We saw an extraordinary response in the first lockdown, and in a sense, the level of engagement and response gave us the opportunity to move from what had originally intended to be a suppression strategy to an elimination strategy, because New Zealanders embraced the request so fulsomely. And I guess the highest level of praise was we actually got our own IMDb rating for our 1 o'clock stand-ups, which and our own channel, and the ratings are ones that I think most Hollywood directors would die for. So that's probably the highest level of endorsement we could get. Thank you.
Yeah, no, I have a similar experience. I mean, in spite of there were certain groups of the Swedish society that we didn't manage to reach as well. On the very whole, communication was essential in getting the amount of response that we actually did get. And that response was enormous. I mean, we did surveys and people said that they changed their life. 80-90% of them consistently go through it. We could follow mobile phone operators, seeing that people stopped moving around. There were side effects, like in the first fall, we didn't have any flu cases at all, which showing that social distancing was really penetrating. We could also follow people work from home. 50% of the Swedish workforce work from home. So people really changed. And in spite of international media saying that people in Sweden kept on living like normal, it was completely wrong. And of course, if you do use a wide angle camera and go and stand in a certain place, it could look like there were a lot of people in the streets in Sweden, but no. I mean, the hotels were empty, the streets were empty, like they were everywhere else. So the impact was enormous.
Well, thank you very much, both. And my Lord, I think we've about a minute to go, but we are coming back, I think at 12:30 with a few...
12:45, I think.
Yeah, 12:45, is it?
Yeah.
12:45.
I believe so.
1:45. Sorry,
1:45, we're both wrong. Yeah, I apologise.
And just to remind co-participants that the deadline for any additional questions is 12:30.
I was going to do that.
Oh, sorry.
That's all right. I'm perfectly happy. You can do my work all the time. Could I remind you, please, to do that by 12:30 in the proper form, please, if you don't mind. So I think we're now agreed. 1:45.
Absolutely.
Thank you all.
Thank you.
All right.